Hi everybody, I'm Dr. Britt Talley, a neurologist in Dallas, Texas, and I'm a writer. I'm board of the Mayo Clinic Neurology, trained at Mayo Clinic, and also an electromyographer, which is a test you do for diagnosis of carpal tunnel syndrome. And so I've written 5 neurology textbooks, which are on Amazon, and I'm talking about carpal tunnel with the speech today. If you'd like to get a copy or see the book I've written on carpal tunnel syndrome, you can go to Amazon Books, and there in the search engine, enter my name, Britt Talley, and that'll bring up my books. And then if you have Amazon Prime, you can get the ebook for free or the print book also. So carpal tunnel syndrome is an entrapment neuropathy of the median nerve at the wrist, and it's the most common neuropathy from an entrapment type found in the human body. Other examples would be one where the peroneal nerve is caught at the head of the fibula, at the knee, and where the ulnar nerve is caught at the elbow. But those are rare. And carpal tunnel syndrome is found in 10% of persons. And it's the cause of it is related to the fact that people with carpal tunnel syndrome are born with a small carpal tunnel, which is a little circle in the base of the wrist. And I'll show you a picture of that in just a minute. So imagine that circle area there is the carpal tunnel. And patients with carpal tunnel syndrome have a small area there, and that's why they get carpal tunnel syndrome. So women have smaller carpal tunnels than men do, and that's why women have carpal tunnel syndrome 3 times more than men do. Now, the median nerve is the nerve that goes to the wrist at the carpal tunnel that's trapped. And I'll show you a picture that shows the fibers of the median nerve coming out of the neck at the cervical region where they're roots, and then roots of C6, C7, and C8 form the carpal tunnel syndrome, form the median nerve. And they go through the brachial plexus at the shoulder area, and then go down the front of the arm, and they pierce through the carpal tunnel at the wrist here. So the carpal tunnel is here, and the median nerve going through there is blocked. Now, the median nerve carries fibers for the motor nerve, for sensory nerves for touch, for sensory nerve for pain and temperature, and some autonomic, very small fibers. If the autonomic fiber is involved, you can get redness or swelling in the hand. If the sensory fibers for touch are involved, you get numbness or tingling. Now, the way our anatomy is made, the brain can perceive touch in our fingers very well. We can locate it cortically well. So that's how we're able to type on a typewriter and hit the letter A or B and things like that, and also to play the piano, because we can tell where our fingers are exactly. And if our eyes were closed and our palm was up and someone touched your little finger, you would be able to say, that's my little finger, because we can feel it and identify where it's happening. But the pain and temperature fibers we cannot locate as well, and sometimes we're just able to say it's on like the right side of the body or something like that. So even though the carpal tunnel syndrome is a pinched fiber for pain and temperature at the wrist, the pain of that can be perceived at the wrist, the forearm, the upper arm, or even in the shoulder, which is confusing. And sometimes doctors will order an MRI scan of the cervical spine looking for a herniated disc at that location in patients who have symptoms that are related to numbness and pain in the arm, which is confusing for the doctor to sort out. That's whether it's a pinched nerve, which we call a cervical radiculopathy, or whether it's carpal tunnel, a trapped nerve at the wrist. Okay, so the findings, the fact that the median nerve pain fibers are not well localized is what is called referred pain. And referred pain is found in 2 other things in medicine I'm going to explain, which most of you will know about and can understand. If a person has coronary artery disease, which is narrowing in the arteries in the heart, and they get what's called the symptom of angina pectoris, which is chest pain that comes with exertion, like shoveling snow in the winter, someone gets chest pain. Not all the time is the pain from the heart referred to the chest. Sometimes it's referred to the left arm, or even to the chin, or to the back of the neck, which is weird. And one wouldn't think that's a heart problem. But you just have to know the anatomy, that it's referred like that. And doctors learn things like in the training for medicine. Another thing that causes referred pain would be a herniated disc, let's say at L5S1, where in the back area, that's about at the waist area where the belt is in the back, but it causes pain down into usually in the leg. So that's referred pain. The problem with a herniated disc is happening at the belt level, but I feel the pain in the leg. So carpal tunnel is a referred pain syndrome also, where the problem is at the wrist, but the patient complains of pain in the wrist, the forearm, or the upper arm. Now, if the motor fibers involved, you'll have weakness, because what the motor fibers do mainly is causes the thumb to grip things. So there are two muscles that'll do that. And they really close the thumb towards the pinky and close the hand like you're holding on to like a pipe or something like that. Now, if those fibers are involved, you can have weakness in the hand, typically for opening a jar, because you use that act of turning your arm like that, which tightens up the jar so you can turn it. But if your thumb can't do that act very well, the hand's weak and you can't open jars. Or sometimes patients will drop things a lot and they'll complain of that. Okay, so the symptoms of numbness and tingling are usually the first symptoms, and those usually are expressed from sensory nerve involvement. And the typical situation there will be the patient wakes up at night with their hand numb and tingly or asleep, which is the most common diagnostic feature of carpal tunnel syndrome. Or the patient may get numbness and tingling provoked by activity, and it may come episodically at the first, like driving a car. While you're driving a car, the hand goes numb, but when you quit driving, it goes away. Or typing on a keyboard, or using a mouse, or digital entry somehow into the phone can do it, using a hairdryer, or any kind of vibrating thing. In fact, vibrating tools can really bother peripheral nerves. And so some of the worst and most symptomatic cases of carpal tunnel syndrome that I've seen in patients who do vibrating tools, like the sidewalk dentist who has this vibrating thing where they break up cement and make a lot of noise. Or I had a patient recently who ran a polisher for a floor. He ran with his hands and it vibrated in his hands. He had horrible symptoms of carpal tunnel syndrome, because vibration is really bad for peripheral nerves, and particularly the median nerve in the wrist for carpal tunnel syndrome. All right, what kind of findings will you see on neurologic exam? Well, what does the doctor do? Generally, you should check all the muscles in the upper extremities, and particularly the muscles that have to do with the median nerve, which is basically flexion of the thumb at the tip, and also opposing the thumb against the little finger, that act. Sometimes you will see atrophy in the base of the thumb and what's called the thenar eminence, which is here. This big muscle's gone there, and you can see that. That's usually with chronic carpal tunnel syndrome. All right, so you'll see in the picture I have on carpal tunnel syndrome, the median nerve fibers starting at the neck, and they come down the arm. You can see that the median nerve in 75% of persons goes to the palmar surface of the thumb, the index, the middle, and half of the ulnar nerve, whereas the fifth digit, which is called the pinky, and half of the ring finger, of the fourth digit, are usually innervated on the palmar surface by the ulnar nerve, and the radial nerve goes to the back of the hand usually. Now there could be differences in that, like an all ulnar hand, but that's pretty rare. That doesn't happen very much. So if a patient says they have numbness and tingling in the first three digits, well, that's usually found with carpal tunnel syndrome, because that's where the median nerve goes. Okay, so those muscles should be examined, and then there are two provocative tests that can be done in the office which can help the doctor understand the patient may have carpal tunnel syndrome. And the first test is called the Talley sign, where the doctor taps the nerve at the wrist, and if the patient says it causes numbness or tingling in the hand, that's a positive finding for carpal tunnel syndrome, and I'll show you a picture of that right here. The other thing that can be found with carpal tunnel syndrome is called the Phalen maneuver. It can be done where the hands are forward flexed against the chest for 60 seconds, which is a minute. If the hands go numb and tingly during that time, that's said to be positive Phalen maneuver for carpal tunnel syndrome. That's P-H-A-L-A-N. And that was Dr. George Phalen. And I'll show you a picture of the Phalen maneuver. Then I'll show you a picture of Dr. George Phalen, who was a pretty famous orthopedic surgeon who in 1950 wrote the original articles describing the syndrome of carpal tunnel syndrome, and at that time used the Talley sign and the Phalen maneuver as tests in the office to make a diagnosis. Whereas nowadays we have electromyography, which can help, and also an MRI scan to rule out a herniated disc. Reflexes in the arm should be normal. The sensory exam for vibration and things like that should be normal in the hands. Sometimes you will find a median sensory neuropathy when you take a small pin and you test for pinprick sensitivity on the palmar surface of the thumb, index, and median. In the middle, and the third finger, you may find lack of perception of pin, and that's called, median sensory neuropathy. And that's usually found with more developed carpal tunnel syndrome. So the first symptoms are usually numbness or tingling, which may happen over months, can be episodic, and then if the problem gets worse, they become continuous. And when that happens, the Talley sign, the Phalen maneuver, are usually lost. Also, you can find next the median sensory neuropathy, where the patient can feel pin over the fingertips. And finally, you'll find atrophy at the base of the thumb. Okay, the tests that are used for evaluation or checking out carpal tunnel, as already mentioned, would be an MRI scan and also electromyography, where you put electrodes on the hand and shock the median and ulnar radial sensory motor nerves and see if the nerve's blocked at the wrist. And also by doing electromyography, we can tell if the patient has mild, moderate, or severe carpal tunnel syndrome. Patients that have physical findings, in my mind, of atrophy in the hand, really have chronic carpal tunnel, or who have the median sensory neuropathy, those usually have pretty well developed chronic carpal tunnel syndrome. And if I then do an EMG and they find that they have moderate or severe carpal tunnel syndrome, they should be evaluated with a surgical opinion. Excuse me. So that gets in to the next comments on carpal tunnel syndrome, which how do you treat it? Well, you ask patients to rest their hand, because carpal tunnel syndrome can be an overuse syndrome. And who gets it? The risk factors for carpal tunnel syndrome, as I've mentioned, are women, particularly pregnant women in the third trimester of pregnancy. They may get the symptom related to edema fluid accumulating in the mother's body. And there's usually a quick fix for that, as she diureses and voids out all that fluid after the baby's born. People who are obese have a risk factor for carpal tunnel syndrome. Diabetics with neuropathy have an increased incidence. And also, anyone who's had a fracture for the wrist or the forearm earlier in life can have a risk factor, mainly due to scarring around the nerve, which blocks it later as time goes by. So the treatment first in those folks is to rest their hands, which is hard to do, but you try to get them to rest their hand for scrubbing and doing things like that. You can get them to wear a neutral splint at night. And I'll show you a picture of a neutral splint. It's just a splint that's got metal on the palmar surface here. It's got little Velcro snaps that hold the wrist in a neutral position. I'm going to show you with my fingers sort of what happens with carpal tunnel syndrome at the wrist. Okay, my hand is straight out, so the tunnel is open. But if I bend my wrist, it closes the tunnel, or if I extend the wrist, it closes the tunnel, puts pressure on the nerve, and then the hand goes to sleep. An example of that would be to conceive of something like this. Imagine a hot dog being squished by a pair of pliers, and the soft tissue of the hot dog would be damaged. It wouldn't work well. So the median nerve is sort of soft tissue, and it gets trapped inside this bony tunnel with bone on one side and a hard ligament on the other, and it blocks the nerve function, and it quits carrying electrical signals, and the hand goes to sleep during that time. And that states why wearing a neutral splint straight out will help treat carpal tunnel syndrome. So the patient should be advised to rest their hands and sleep in a negative splint for about a month or two and reevaluate and see how they're doing. Many patients I see are sort of put off and disappointed by that advice because they want something dramatic to be done with their horrible problems. But I just tell them to hang on, that resting and splinting is powerful. And many patients, when you see them back in a month, are pretty much asymptomatic and do really well. If they don't do well after resting and splinting once or twice, 1 or 2 months, you can inject a shot of cortisone in the wrist. You can do that once, followed by, in another month, a second injection. I tell my patients, injection of cortisone in the wrist hurts pretty bad. On a scale of 1 to 10, the pain goes straight up to 10 within seconds and stays there a minute or two, and then quickly goes away. I know that myself because I have had carpal tunnel syndrome in my right hand, and my office nurse gave me 3 different shots of cortisone on my wrist, which always helped for a month or 2, but then the symptoms came back, so ultimately I had to have surgery. And so what's the deal on long-term treatment of carpal tunnel syndrome? Well, 90% of patients are treated conservatively with resting, splinting, and 1 or 2 cortisone injections. But 2% of patients fail that, symptoms become chronic, and if they have an EMG that shows moderate or severe carpal tunnel, or they have physical findings, as I mentioned before, those people at least should have a hand surgeon opinion. Now, the Mayo Clinic says the most successful surgery of all surgeries is carpal tunnel release, where the surgeon goes in and cuts the transverse carpal ligament, which binds the tunnel, and does surgery for that. So about 90-something% of patients after carpal tunnel surgery do really well and great. I'll show you a picture of that here. So thank you very much for watching this. I hope it helps all you people with carpal tunnel syndrome. See and talk to your doctors, neurologists. If it's really bad, consider getting an EMG, maybe an MRI scan. Hope you do well with treatment, and God bless you all.